Thank you for having me here. Today I'll be talking about Nirmatrelvir, Ritonavir for the treatment of long COVID, findings from the STOP-PASC clinical trial. In terms of disclosures, the STOP-PASC clinical trial is funded by and conducted in research collaboration with Pfizer, and the digital wearable sub-study of this trial was conducted in collaboration with AI Care. First, what is long COVID? Long COVID is known by many names and acronyms, PCC, PASC, PACS, colloquially COVID long hauler. And it's a huge public health problem, a global issue. An estimated hundreds of millions of people around the world have had long COVID or continue to have long COVID. And an estimated 6% of all adult Americans still have long COVID as of summer of 2024. And estimated millions of jobs, at least in the United States, have been lost because of long COVID. So it has had huge, of course, societal impact and economic impact as well. The definitions, there are multiple definitions, and the definitions have evolved over time. And recently, in June of 2024, the National Academies of Science, Engineering, and Medicine in the United States has reached a consensus definition after much work with multiple stakeholder groups, including patients and community, physicians, researchers, and others, to formulate a definition that can be applied to multiple purposes. And their definition that was was long COVID is an infection-associated chronic condition that occurs after SARS-CoV-2 infection and is present for at least 3 months as a continuous, relapsing and remitting or progressive disease state that affects one or more organ systems. Key terms here are it's a chronic condition, at least 3 months, and it can have different illness patterns and trajectories, and it can be multi-system. Long COVID is really a syndrome of syndromes. It's an umbrella term that encompasses many different subtypes or subconditions under it, including sequelae directly from the acute infection, as well as hospitalization complications, and overlap with other syndromes that have been known previously to occur after viral infections, such as chronic fatigue syndrome, dysautonomia, POTS, and other conditions as well. So it's a complex syndrome of syndromes, and therefore likely the cause of it that underlies, the reason that people have persistent symptoms is likely to be complex as well. These are some of the top hypothesized and leading models of mechanisms that cause long COVID, including immune dysregulation, microbiota dysbiosis, autoimmunity and immune priming, blood clotting and endothelial abnormalities, and dysfunctional neurological signaling. These are not mutually exclusive, of course, and some of these can be overlapping in terms of pathways and may be occurring in individuals, as well as different combinations may be occurring in different people. And I'd like to highlight here as well that one of the leading hypotheses about what might be causing long COVID includes persistence of SARS-CoV-2. Viral particles have been detected in different tissues, and therefore the question is this a potential target for therapy as well? And this could lead to both a chronic inflammation and immune dysregulation, as well as microbiome dysbiosis and other issues as well. And this is what will be the rationale for the trial that I'll be talking about later. So how do we treat long COVID? There are currently no approved and well-established therapies for long COVID. So there is an urgent need for clinical trials to address this huge issue. But there are challenges in study design for clinical trials for long COVID. Well, first, there's an evolving understanding and even definition of long COVID. As mentioned, it's a syndrome of syndromes, an umbrella term, so it's extremely complex, and there's a variety of clinical presentations and many different types of symptoms that can occur. There are, at this time, no validated clinical endpoints for clinical trials, nor validated biomarker and objective endpoints for clinical trials in this space. There's also, at the time that we designed our study, there was a lack of precedence in the literature in terms of endpoints and outcomes and published guidance from regulatory agencies at that time. But yet, we move forward because of the urgent need to find answers and to test hypotheses. And our trial, the selective trial of Paxlovid for PASC, STOP-PASC, was a signal-seeking study. And the primary objective of that study was to evaluate the efficacy and safety of a 15-day course of Paxlovid versus placebo in reducing symptom severity in participants with PASC, aka long COVID. We also had exploratory objectives for this study, and it was a multi-purpose study. There was also an objective to investigate potential biological biomarkers of PASC, as well as to investigate potential digital biometric biomarkers of PASC. The design of the study was as such. So adults with PASC were randomized 2-to-1 for Nirmatrelvir Ritonavir. Acronym from here on forward will be used NMV/R, or to placebo ritonavir. Acronym will be PBO/R, for a 50-day treatment period. And this is in contrast to acute Paxlovid use in SARS-CoV-2 acute infection, where the treatment period is for 5 days. So this is a prolonged use of 3 times the duration of the acute period. Then there's a follow-up with study end at week 15, and the primary endpoint was selected at week 10. During the course of the study, participants underwent symptom surveys to look at some core symptoms as well as expanded symptoms that were selected based on some of the most common symptoms that individuals with PASC experienced, as well as some of the most burdensome and symptoms that were thought mechanistically to likely arise if there were viral persistence. Patient-reported outcomes, although they're not really great validated PROs that are used here in the field, we did use other ones that were often used, such as PROMIS surveys in other related conditions. Clinical assessments, such as vital signs, orthostatics, a functional sit-to-stand test, and then biosample collection for laboratory testing and for biomarker analysis, as well as digital wearables, an optional opt-in sub-study where people can wear an Apple smartwatch to monitor physiologic and behavioral parameters such as physical activity and heart rate, oxygen, and other parameters. This is our consort diagram and the flow of recruitment and enrollment. Participants in the study were mostly from the general community, both regionally in the state of California as well as out of state. And many were also from the long COVID clinic here at the Stanford Center. Key inclusion included confirmed index COVID-19 infection, 2 or more moderate or severe core symptoms. We define core symptoms as based on these 6 symptoms: fatigue, brain fog, dyspnea or shortness of breath, body aches, gastrointestinal symptoms, and cardiovascular symptoms. We had many individuals who expressed interest, but many were excluded. Some of the most common exclusion reasons included drug-drug interactions with the Nirmatrelvir Ritonavir drug. And 155 were eligible and randomized to the study. So this is a summary of what our population looked like and some of the baseline characteristics. 59% of the study population was female, 74% of white race, and median age was 43 years old. And again, 155 participants were randomized in about a 2-to-1 ratio. And so 102 people received the active study drug, Nirmatrelvir Ritonavir, versus 53 who received placebo Ritonavir. And baseline characteristics also included that nearly all participants, except for 2, had received the primary series for COVID-19 vaccination. And the mean time between the index, their initial SARS-CoV-2 infection that led to their symptoms, and randomization was 17.5 months. So it reflects a population that generally had a prolonged course of over a year of symptoms. Fatigue and brain fog were the most reported, self-reported symptoms by the participants who enrolled in the study. In terms of safety, so what do we find? Adverse events in terms of 15-day course of Nirmatrelvir ritonavir compared to placebo ritonavir, we found similar rates of adverse events as a whole. And in terms of total serious adverse events, there were only a few, and there were very few, and in both groups, 3 were unrelated to the Nirmatrelvir ritonavir group, and 1 was possibly related in terms of hepatitis, which has been known previously for ritonavir. And most of the adverse events were mild grade, with a handful who were in the moderate range, and no fatalities. In terms of symptoms, which was our primary interest in symptom severity, here we have a graph showing over time with the x-axis of weeks from 0 to 15 and y-axis of participants, percentage of participants. And this is showing placebo in this column. And you have the 6 identified symptoms that we were interested in, which are called the core symptoms: fatigue, brain fog, body aches, cardiovascular symptoms, dyspnea or shortness of breath, gastrointestinal symptoms. The shading here is the darker shade is a more severe symptoms. The severity is more severe, and lighter shade is less severe or none. And so you can see some of the patterns for these different symptoms over time, where many people had severe fatigue or moderate fatigue. And over time, that proportion actually decreased. And this is in the placebo group, and that's of important note. And if we also compare to the column, which is the intervention, the study drug, Nirmatrelvir ritonavir, overall, you can see that there's similar patterns, and therefore no striking differences. But in both groups, again, you also see over time some degree of improvement for the proportion of people experiencing severe or moderate symptoms. So we found overall no benefit of Nirmatrelvir ritonavir compared to placebo ritonavir for these 6 symptoms using our measurement metrics. There was some improvement over time in both the arms, but still, if you look at week 15, a substantial proportion of individuals still did have symptoms at week 15. And this is another way to look at how participants felt. These are global impression scores, so rather than looking at individual symptoms, participants are reporting their overall impression of symptoms. This is a PGIS, looking at just how they feel symptom-wise in general, with the extremely severe being orange and severe being yellow, and in the more blue zone being mild or not present. And you can see over here at baseline, there were a portion of people who had severe or extremely severe symptoms, and over time, more proportion had milder symptoms. And similarly, PGIC is a global assessment of generally how they feel compared to baseline at these different time points. And you can see over time that there's a higher proportion of those in the blue range, which is more mild or much improved or very much improved. Although there are still a few subset who did feel worse over time as well. So there was heterogeneity in terms of trajectories and pattern. The key findings from this trial: we demonstrated feasibility of a complex protocol with high level of patient engagement and retention in this patient population. 15 days of Nirmatrelvir ritonavir demonstrated an overall favorable safety profile in this patient population and has never, been studied in this patient population before. This was the first study to look at this study drug in this patient population. And the clinical efficacy analysis did not find benefit of 15 days of Nirmatrelvir ritonavir for a subset of the 6 PASC symptoms that we selected in a mostly vaccinated PASC cohort with prolonged symptoms. We obtained a rich clinical data set for multidimensional integration with exploratory data that's to come, including biomarkers, both in terms of molecular as well as digital wearable data. So for future directions, Additional analyses are ongoing at this time, including ancillary clinical analyses. So this is our overall cohort and our findings. But there may be, as I mentioned, there's a lot of heterogeneity in participants' trajectories. There may be subgroups of interest or that have signals that should be explored further. Additionally, we are looking at some of the exploratory biomarker studies, both for molecular profiling and immune profiling, as well as digital wearables, and seeing if some of those could be valuable endpoints to use in terms of objective markers of physical activity or physiology, such as heart rate and oxygen heart rate variability. So that information analysis is to come, and we're excited to share that in the future as well. Additionally, this is a first step. I think it's important that although we did not find a signal based on the metrics we used, based on this cohort who had, certain features like highly vaccinated and as well as protracted symptoms, it's possible that when you look at different symptoms, when you look at a different population with different endpoints, there may be a signal there. I think that's to be determined. And there will be interesting to see the results from several of these other studies that are ongoing right now, also testing Nirmatrelvir for PASC. And that includes the NIH Recover Vital study. They're testing both 15 days and 25 days. And it's a multi-site around the country of the United States, as well as at Yale, they're testing 15 days, and at Karolinska, testing 15 days as well. So several studies designed all slightly differently, and together we'll be better able to inform whether or not Nirmatrelvir or Ritonavir can be used as an effective and safe therapy for long COVID. And with that, I'd like to acknowledge our lot of collaborators and teams that went into this effort, including at Stanford, as well as our Pfizer collaborators, and of course our patients, our participants, caregivers, and community advisory board. So thank you so much for your attention.